Our next speaker, who is going to continue the discussion of how race influences medicine, is Dr. Fay Cobb Payton. Dr. Payton is a professor of information technology and analytics at North Carolina State University. She was named University Faculty Scholar for her leadership in turning research into solutions to society's most pressing issues. Dr. Payton works on projects related to smart health and biomedical research in the area of artificial intelligence and advanced data science. She has spoken extensively on the risk of digital discrimination, exploring AI bias, artificial intelligence in healthcare and race, artificial intelligence and systemic inequities. Today, she is going to discuss the intended or unintended consequences of including race in clinical algorithms and how we can use AI to improve, not harm, health for people from all racial backgrounds. Dr. Payton?
Thank you. Thanks for inviting me today. So I'll put this disclaimer out. It is great to be here, and we will go ahead and get started. So I will start with some research findings from a group of colleagues and I who have been studying healthcare and particularly using large data sets to discover any insights on particular healthcare conditions. And I start with two very enthusiastic people, I'm sure many of whom you know. And this was our experience in the lab, thinking we got data. And by that, we were excited, we were ready to go out, do some analyses, and draw some conclusions and come up with some recommendations. So we had the data, as Picard would say, and everyone has data, as Oprah would say. So study one, we took a look at the idea of diabetes in hospitalized patients. And our goal was actually to take a look at sex and race. And we were particularly interested in comorbid conditions, the degree to which diabetes exists, but other health disparities, or as defined by the CDC, are prevalent in a patient data set. Our team, as we're talking about the data, we started out with, as you can see, almost 48 million records, discharge records, over a huge latitude of time. And we were pretty adamant that we were going to be able to track patient A or patient B all the way through this time period from 2006 to 2011, as they had experienced in the intake process, and if they did have that experience, hospital experience. We whittled down, this is sort of a schematic to say, you know, we are not really going to look at anyone that's admitted for new birth or newborn delivery, anyone that is less than 18. And as you can see, we had a number of discharges with missing values that were excluded. And I think there is something to be said about when we grab on and hold on to these data sets. The data, as you well know, comes with many different attributes. We were looking at age, gender, race, total cost, length of stay, and discharge disposition. What we found and what we learned was this. We came up with this schematic to sort of take a look at who has diabetes, who doesn't have diabetes, what are the comorbid conditions that cling to and with diabetes. Is it obesity? Is it heart disease? Is it mental health? We wanted to discern how this affected and infected those based on their sex, based on race and ethnicity. What are the total charges, length of stay, and again, as we mentioned, the disposition. This representation shows the relationship between variables and outcomes of interest. The population of interest was separated by these variables to represent sort of that inner circle. The primary variable of interest, comorbidity, is presented in the light gray. Variables in the following dark gray represented demographic variables, while those in the black section represented the primary outcomes of interest, which are in this outer ring. What did we learn? We learned from our initial results, which took quite a bit of time, and hence why this is important when we are designing algorithms. Initially, we started out, as you could see, with that very large data set of over 47 million, or right at 47 million. We were not able to use all of the data. We needed to take a step back. We needed to do some data scrub. We needed to ask questions around the comorbidities and the coding of ICD codes that were in the data. We learned that for a principal reason for hospitalization was that disparities in outcome for women and ethnic groups were persistent. We learned that ethnic groups have poor outcomes and are less likely to have routine discharges from the hospital. We learned that these disparities have persisted over the time horizon for the data sets that we had, suggesting that without conscious effort to personalize the care for women and diverse groups with diabetes, their outcomes are not likely to improve. We also determined and concluded that there could perhaps be a differential impact of diabetes, definitely between men and between women. Homogeneity in patients and comorbidities was rare, or is rare, given the variability of demographic characteristics. In other words, oftentimes an algorithm, or as models are set up, they are looking at a specific disease condition. We wanted to know, how did this impact length of stay and cost of care when other comorbid conditions can be present? We then took a look at a second set. Based on the diabetes study, we were interested in the same sort of topology there, looking at the impact of mental disorders on HIV. By looking at these disorders, we came up with ICD-9 codes at the time, and really learned, and this is something that we also learned from the diabetes study, when we're talking about data, when we're talking about how attributes are defined, when we're talking about fluctuation and changes in ICD codes, particularly in healthcare, having that longitudinal study for implications for the long run can be very difficult. We did run into these problems, particularly when we were talking about mental health. What we learned, and you can see here in the bold, to my left, your right, we found out that there was the existence of non-dependent abuse of drug dependence, depressive disorder, mood disorders, all the way down to schizophrenia, that really creeped up and weighed more into this model. The results of our principal components analyses showed some of these disorders as primary conditions that actually had more weight in the model. What did we learn in this case? We learned in this case, we learned longer length of stay and comorbid conditions do affect HIV patient outcomes. Mental health disorders generally result in a decrease in both length of stay and total charges. Patients with mental illnesses are more likely to be transferred to other facilities, so that their true length of stay actually is not observed. We found that there was actually some disparity when we looked at race and ethnicity. The most important conditions that bubbled up for this model were mental health disorders, and we placed the codes out here. Mental disorders, mood disorders, depression, and anxiety. The key takeaway that we learned is that health services and health services delivery approaches to adherence and treatment to better address chronic diseases and their severity, along with the comorbidities, are truly needed when it comes to race and race-based medicine. We turn to a more salient issue with another study, looking at, again, large data sets, this time using natural language processing and really looking at what have other studies done to inform us about how we deliver healthcare, particularly healthcare pre-COVID, I should note that this study is, to college students. What we learned is that the majority of the research was focused on not on age, not on race actually, but more so what are the services that were needed. Many a study were looking at what are the services that institutions can provide and how they can provide them to address, in fact, issues of age and race and crime and the aftermath of that impact of having a challenging experience on an institutional's campus, as well as what are the issues around victimization that leads to mental health in the first place when it comes to our college students. When race inclusion or when race is excluded, what we know, and this was mentioned earlier by Dr. Jones, but I want to highlight some of this. Race blind algorithms may be well intended. Race blinded oftentimes can heighten disparate conditions and experiences, as we found with the study of mental health and the study of diabetes. Race blinded actually heightens structural inequities that often go unacknowledged in an algorithm. Race blind, where healthcare costs as a proxy, as we know, Augerminer and group from the Science publication, that the algorithm falsely concludes that Black patients are healthier than equally sick white patients. In other words, fewer resources being spent on Black patients who have the same level of need. Why does all of that matter? And so what is missing in the discussion? Healthy People 2020 points out the social determinants of health is based on 5 place-based domains. And I think these are the domains that are critical, even if the team and I were to go back and look at our results from earlier years. There is the economic stability of patient populations, variability in education, health versus health care, neighborhood and built environment. I think earlier Dr. Jones mentioned zip code, social and community context, very much in terms of discrimination being a key issue in the social and community context domain. While all of that is good, I do say, and I've often used this as a talking point and try to include this in the research, that big data, this was as a note from the Washington Post, big data was supposed to fix education. Like there was a lot of hope placed on big data in healthcare. It didn't fix education. It won't fix healthcare. But it's also time to have models that are sensitive to small data being context, which are really important. What I mean by that is, here's a topic that we took a look at about how do we engage, and how do we engage both from an algorithmic perspective, but also from a cultural perspective. While time won't permit me to discuss all of this, the myhealthcareimpactnetwork.org started out as a platform to have discussions with young people around health disparities. The infographics are out there to show what are the other issues salient of a binary on versus off, good versus black, bad, black versus white sort of construct. What are the other issues that actually come into play when it comes to understanding healthcare and healthcare outcomes. Historical context is critical. Think about the time period of the story for which you are running that algorithm, telling that story. What events are critical? We all know that we've had the trifecta of COVID, an economic downturn, and sort of racial strife here in the country. What could the author, what could you do in terms of using a historical context to impact your plot, your analyses, your implications, your recommendations? How does this inform the reader? Historical context matters. It is not just a data issue. I highlight these types of association biases that come into play when it comes to healthcare. It's not just a data set bias, there's association bias, there's automation bias, confirmation bias, and interaction biases. And lastly, I put up this was actually released, as you can see, a few days ago. While there is a lot of talk about health disparities and what algorithms could do, health equity and health disparities and the role of representation in the space do matter. Particularly when it comes to data science and decolonizing data and health disparities to tell the picture of who is designing the algorithms, what is the context, and are there populations that are missing from the team? And this is my last slide. The lived experience and algorithmic bias. There are models of fairness that exist out there. But I'd say small data, social determinants of health, place and space. There must be an ecosystem thinking. Healthcare does not exist in a vacuum. Data sanitation, which we definitely learned in the studies that I talked about, the training data, the validation data, and the test data all have implications for over and underfitting, which has impacts on populations. And again, context matters. Augmentation of AI findings relative to how the results will be interpreted and used and informing policymakers, all centered around the concept of design justice, centering race in design so that it will not be absent and it will not be overlooked. And with that, I will turn it over to you and thank you for having me.
Thank you so much, Dr. Payton, for such a powerful and insightful look at these really genuinely complex issues.